5, 4, 3, 2, 1. Sir, we are live now.
Yes, thank you. Thank you guys, all of you, for joining us today. It's a hot topic, and I'm sure we're going to have many more participants coming in. We are talking of thoracolumbar fractures, something that's very, very common in your practice as well as in the exams. And we have none less than one of our very senior and experienced orthopedic spine surgeons from Bombay, Dr. Raghu Prasad Verma, who's also the president of the Spine Foundation. So we've given appropriate respect to this topic. Let's try to dive into it. While we warm up, Dr. Manoj Gadikeri, one of the associates from the WeAreSpine group, will present a case and just raise the questions that we are about to answer through this talk, followed by a lecture by Dr. Raghu Verma. Manoj, over to you.
Okay, thank you, sir. Okay, is this visible, sir?
Yes, we can see and hear you, Manoj.
Okay. Good evening, everyone. Myself, Dr. Manoj Gadikeri. So we'll be starting with a few case presentations of thoracolumbar fractures and their management. So coming to case 1, here's a 24-year-old male who comes to us with a history of fall from bike. He presents with GCS of 15. There is local tenderness present in the lower lumbar spine with neurology is intact. He presented to us with this X-ray. As we can see, there is a compression fracture at around L2 level. And moving on to the CT scan, there appears to be a burst fracture with retropulsion of the fragment, and the level is at L1 with mild canal compromise. On moving to the MRI, you can see that the canal is pretty much wide with no significant cord compression. So I'd like to ask that in such cases, the classification of AO, if anyone will be willing to answer. Sir, are we taking any questions? Can we ask?
I think Dr. Vaishyak or Dr. Nitin, you can actually come in here. Can anyone want to give their opinion? How would you basically justify your assessment of this fracture and planning?
Sir,
yes.
Sir, this L1 fracture looks as if that this White and according to White and Punjabi's classification, so there are 3 columns to this spine. So it seems that the first column and second columns both are compromised. So this seems to be an unstable fracture, and this unstable fracture without any neurology, without any canal compromise, deemed to be fixed. Yeah.
So I'd like to clarify this, sir, that the 3-column injury is not from White Punjabi, that is from Dennis classification. And White Punjabi gave the instability scoring, and the current classification which we follow is an AO classification.
Okay.
So
Nitin, which according to you is the most important of the 3 columns? Nitin?
Yes, sir. Yes, sir. Yes, sir.
Which of the 3 is the most important columns?
Sir, it seems, sir, intermediate column, sir. I'm not sure, sir. Intermediate column, sir.
Middle column.
Middle column, sir.
I think you're right in terms of, one of the 2. But today, the whole world is looking at the posterior column, because if the posterior tension band gives way, the fracture from stable becomes unstable.
G.
So in this fracture, do you think the posterior column is intact?
Sir, can I chip in, sir?
Yes.
Yes, sir. Since it's a 24-year-old boy, sir, with neuro intact, but this fracture seems to be unstable type A3, AO A3 type, with superior end plate collapse and with more than 2 column injury, sir. I think with the present scenario of segmental kyphosis at L1 and based upon the TLI scoring with posterior complex intact, but still with the kyphosis at this junction, I think operative management will be much better in terms of structural So, sir.
So Vaishak, you're calling this an unstable fracture and you'd like to stabilize it to prevent further kyphosis, isn't it?
Yes, sir. Yes, sir. True,
Can
sir.
you quickly tell us how could you score this on TLIC without a CT scan?
Sir, with MRI, I would like to comment upon the morphology of the fracture. Then about the posterior ligamentous complex, and with neuro being intact. I think the scoring.
Okay. So Manoj, can you clarify these questions? What is the
Yes,
AO
sir.
type and what is the TLIC type and why?
Sir, according to the AO, this comes as an AO type A3, which is a stable burst fracture because the inferior end plate appears to be intact, sir. And according to the TLIC score, the score is 2 plus 2, sir. That is, there is, according to the fracture morphology, it's a burst fracture, so 2. And the PLC is, there is intermediate, it's an indeterminate injury because there is localized tenderness, and on MRI, there is no clear-cut sign of a PLC disruption. The total score here is 4. And according to TLIC scoring, a score of less 3 and below is to be managed conservatively. A score of 5 and above has to be operated. That's a better line of management. And a score of 4 is a gray zone where the decision has to be taken by the treating surgeon, whether to go with the conservative or the operative treatment.
Fantastic. So Manoj has kind of summed it up. Any questions or doubts? Manoj, what did you do then? Do you have a
Sir, in this case, we went with the conservative management. Patient was young, and so we went with a short period of bed rest, and then we started mobilization with an ash brace.
because the scores suggested that this should be conserved.
Yes, sir. The neurology was intact, and the PLC integrity was pretty much present, sir. So we went with the conservative line of management in this
What
case.
do you feel about Vaishak mentioned about long-term kyphosis? What is the likelihood here?
There is a likelihood of developing postoperative kyphosis, sir, but the literature suggests that up to 30 degrees of kyphosis is better tolerated, and there is no chance of further progression if the kyphosis, localized kyphosis at the thoracolumbar junction is around 30 degrees or less. And in this case, it was around, it is below 30 degrees, sir. And with subsequent X-rays during the follow-up, we saw that the kyphosis is not worsening. So I think.
Perfect. Vaishak, do you have anything to say here?
Nothing much, sir. Maybe to keep him on close follow-up would be better for his long-term outcome.
Right.
Outcome.
Nitin, you've raised your hand. Quick.
सर मैं ये कह रहा था सर ये इंजरी तो अनस्टेबल लग रही थी सर दो कॉलम खराब हुए थे
क्यों अनस्टेबल
सर एक से ज्यादा कॉलम खराब होता है तो इंजरी अनस्टेबल होती है सर
बट दैट वाज माय क्वेश्चन कि एक से ज्यादा अगर हो तो कौन सा क्रिटिकल कॉलम हो जाता है क्योंकि मिडिल कॉलम तो बकायदा हो ही जाता है अनस्टेबल मींस इन्वॉल्व तो मिडिल विथ पोस्टीरियर कॉलम कैन बी मोर अनस्टेबल बट मिडिल विथ एंटीरियर कॉलम नीड नॉट बी अनस्टेबल स्पेशली इफ वन एंड प्लेट इज प्रिजर्व्ड
जी सर
तो एओ क्लासिफिकेशन का जो ग्रेडिंग है ना दैट गोज फ्रॉम लेस स्टेबल टू मोर स्टेबल टू लेस स्टेबल so it's deciding the Manoj, do you have a slide of AO classification or
yes,
Raghu? If you have that slide, this might be a good time to quickly touch upon.
So I'm going to look at that up here. So we've got example related and we have correlations with something. So I think it'll catch you.
Why not move to your talk then?
Yeah, sure.
Anyone else has anything to ask? Arvind, Archit, Gaurav, anything? Harsh?
Hello, sir.
Yes. Virendra.
Yes, Dr. Virendra. What is the TLIC score? How to score that? How to count that score?
Sir,
Raghu, are you going to cover that?
Yeah, I'm going to cover that. Yeah, okay. Sure. It'll be looked at basically. So we'll go through it.
Any other questions?
Sir, excuse me, sir.
Yes.
So what is that short period of rest? How long is that bed rest period?
Manoj, you got to answer that.
Sir, we follow a protocol of at least 6 days of bed rest, not beyond that, because beyond 1 week of bed rest, it has no much importance, or it will further worsen the condition than improve. So after 1 week of bed rest, most of our patients are better, have a good pain relief. Then gradually with minimal analgesics, we start mobilizing the patient with a brace. Here we give anterior hyperextension brace in order to prevent further kyphosis.
Basically, rest should be only until pain allows. I mean, once pain allows, you start immobilizing because there's a dynamic support with the muscles. If you keep lying down, those muscles start to weaken. So the role of complete bed rest is no longer valid in at least in scientific practice.
Yeah, okay.
Any other quick comments? What is the follow-up? Someone has asked. What is the follow-up protocol? Is there when do you do an X-ray? When do you call him back? When you start exercises, Manoj?
So we call him back at 3 weeks, sir, and gradually we start mobilizing after 1 week of bed rest itself. Then by the end of 6 weeks, we start with the physio, and we keep following up for at least first 3 months. Every 3 weeks, we keep following up, sir.
Any
And after
X-rays?
that, we take the first X-ray at 6 weeks, and then again repeat it at 3 months.
What about sitting X-ray and dynamic
Yes,
load
sir.
X-rays?
After 3 months, we get an sitting and dynamic, that is a weight-bearing X-ray. That sitting and supine AP and lateral X-rays, mainly lateral X-rays, to see if there is any instability, intravertebral or an intervertebral instability because of this fracture.
Okay, one last comment by Nitin, and then we'll move on to the talk if everyone's okay.
सर अ नाइव क्वेश्चन सर आई वाज वंडरिंग सर 6 दिन में सर कैसे फ्रैक्चर में किसी को दर्द में आराम मिल जाएगा
इतना आराम हो के वो चल सके तो आप उनको अलाउ कीजिए बिकॉज यू विल बी सरप्राइज मोस्टली इट्स इन आवर हेड्स you ask them to sit and they sit. So in England, in one of the prolific centers, day 1 से उनको बिठाते हैं, and in fact उनका decision sitting के X-ray पे day 1 पे करते थे Nottingham में. So it's mainly in our head.
Sir, if it is
yeah.
Sir, if it is a hardworking man, means labor, like working in a field, then you will advise the same protocol for conservative management.
Yes, absolutely. Because they become very stable. Of course, what happens is the bone heals, but the soft tissue injury remains. So they have to get, do much better, harder physical therapy. But we don't have evidence to say that a stable fracture will function better with plates inside than with natural healing. I mean, that's the toss up. Am I clear?
सर एक चीज और कह रहा था सर
यस
सर एक तो बोनी कंस्ट्रक्ट है जो बोनी कंस्ट्रक्ट बना हुआ है स्पाइनल कॉलम का और सर उसके ऊपर में एक एंसिलरी सपोर्ट एज पैरास्पाइनल और लिगामेंट ये सब लगा हुआ है सर अगर एक मेन सेंटर की सपोर्ट के अंदर में कोई चटक हो जाएगी कोई हो जाएगा तो सर एंसिलरी सपोर्ट ना बन के बल्कि वो तो एडवर्सिटी क्रिएट करेंगी स्पाज्म करके एंड समथिंग लाइक दैट.
Not spasm is a protection, na Nitin. Spasm is what the body does to hold that ancillary support. So it's actually a good thing.
Sorry.
But अगर इतना पेन हो के वो बैठ ही नहीं सके तो उसको यहाँ प्रूफ करने के लिए बिठाएंगे नहीं, of course.
Right.
But what happens is अगर आप लेटा के रखो तो how long will you make him lie down? Fracture healing adults में कितने देर में होता है? 8 to 12 weeks.
Yes sir.
तो 8 to 12 weeks उनको लेटा के रखो तो अपने पास प्रूफ है कि by the 3rd week muscle wasting शुरू हो जाती है. So his final result is worse than it would have been, with mobilization and some pain.
Right.
So actually
तो सर फ्रैक्चर हील नहीं जाएगा मतलब मैल हील नहीं करेगा something like that.
ये स्टेबल फ्रैक्चर है ना. अनस्टेबल फ्रैक्चर की टोटली डिस्कशन अलग हो जाती है. This is a stable fracture means the anatomy is such that वो उसको हिलने नहीं देगा.
Thank you sir.
Okay, so Raghu, I think your lecture is now nicely warmed up because you raised all the right questions. Manoj, thank you, and we'll come back to cases after Raghu's lecture.
Yes, sir.
And it will be nice if everyone can keep butting in, and you can butt in because if you put your hand up, sometimes you don't see it. Just unmute yourself and get in the middle. I'm sure Dr. Raghu doesn't mind, but it'll be
not
nice
at all. Absolutely not. I'm good
nice
with the idea.
Cross conversation throughout this very controversial topic.
So what I thought is I'll take pauses in between. So if there are relevant questions, let them not forget about it, and let's handle it at that moment. Just tell me if the screen's seen. So I want to know whether the
it's seen.
Yes.
And 1 second. Sorry.
We can see it. Raghu, just make it full screen. That's all.
I just need to make a full screen. Okay, where is that full screen thing on? Oops.
Sir, will you advise back support when patient is lying down in this case?
Back
to
support
prevent the kyphosis?
Like a brace?
No, sir. Just back support means pillow under that same level.
Like hyperextension. Hyperextension.
Yes, sir. in lying down
We
position.
don't
supine.
follow that, because hyperextension karo, so you're expecting the gaps in the, the compression to fill up, which is going to take again 8 weeks.
Okay.
So we rather do active extension exercises. Unko prone leta ke start doing extensions, active extension exercises. So build up an internal brace. And DLSO brace and ASH brace there has been no, Pankaj had asked, there is no data to suggest DLSO is better than ASH. And one of the most important functions of a brace is the proprioceptive feedback. So even an ASH brace gives you that. It makes the person stand up. In fact, personally, I also don't even use the ASH brace so commonly. I make them do back to the wall standing exercises. So they are asked to stand with their back braced against the wall. So their muscles start developing a memory of standing. But this is a very controversial thing. So you all can challenge and you may not agree with what I'm saying. And I don't have my own data to prove it, but we are just sharing how we do it in our practice. And if it had not worked, we would not be doing it. Okay. Thank you, Raghu.
Okay. So let's start off now. Thanks, Abhay. And it's a pleasure to be here talking to all of you. So what are your frequent questions? Some of them have already been thrown out, So what are you going to ask me? When do we conserve or when do we operate? If you're going to be operating, what's your methodology? What's your criteria for surgery? When would you do it? What time? What approach? Implants? Whether it's intraoperative neural clearance is good enough? Should it be done in all cases? Most importantly, classification. I could see some of them actually kind of struggle with the TLICS. And we have to look at using a classification with its relevance and need. Not just theoretically know a lot of stuff. Now, with more osteoporosis, you have to look at comorbidities which are influencing your decision making. And one last point, which is very important, most relatives will ask you in a neurodeficit, kya chance hai ki mera bachcha chalega? A promise to keep with regard to the neuro recovery. So we are going to look at these points quickly, one after the other. But as orthopedic surgeons, we dwell in X-rays, dwell in CTs, dwell in orthopedic managements. But remember, your first initial moments, even at the area or the scene of the crime, is where your treatment begins. And you cannot challenge whether the A, B, C, and D's are the essentials or not. They are still the essentials, of which we have 4.5 decades of data in literature which says controlling the blood pressure is the top priority. Now, why is it? Because the first 1.5 hours is where the ischemia of the cord sets in. You cannot compromise that period, and therefore blood pressure maintenance from the site to the area of intervention has to be well maintained. Here is where an Indian or a developing country scenario has a problem, because our systemic lacunae in our system is not setting standard protocols. Also, when you reach a center, you have to have a multidisciplinary approach. When things are settled, your detailed clinical examination and neurological evaluation with the ASIA score has to be in place. Life-threatening conditions like head injuries or probably pneumothoraxes or probably anything else which matters more, for example, a pelvis injury with bladder, are priority, but that can't be used as the only excuse not to manage the spine in the golden hour. So non-medical reasons to delay spine intervention unacceptable. I think these are important tenets that you cannot forget. So in that stage, the first question I thought we'll all ask is, when do we use steroids? 5 decades of data in the literature, there is still a dispute. Imagine in 2019, the final word which is said that it is left to the discretion of the attending physician. Imagine literature saying that Nitin will decide what is to be done, Dr. Nene will decide what is to be done, Harshal will decide, or I am going to decide. We still don't have consensus. What we have consensus is, if you are a corticosteroid favoring individual, do it in the first 8 hours. Now, why is it important? Just like I said, blood pressure, the first 1.5 hours is crucial for ischemia. The period from 1.5 hours to the next 24 hours is where all the pathways are happening, which is leading to destruction of the cord. And generally, the action that happens by methylprednisolone succinate, which is the commonest use, is inhibition of the lipid peroxidation mechanism. That improves calcium hemostasis, that improves blood flow, that improves aerobic metabolism. All things get better by this mechanism, and that has to happen before the first 8 hours. That's why in 2017, AO said, if you're going to be using steroids, use it in the first 8 hours. Now, all of us read in these books that you have to use the standard 30 milligram per kg IV over an hour, and then you infuse it to the 5.4 milligram per kg over next 23 hours. A lot of drug reactions, a lot of issues have happened with this drug regimen. If you ask me, how do I cheat? I cheat by giving a gram in 250 cc normal saline over 1 hour, and then give another repeat dose at 12 hours of 500 milligram, and do it once a day of 500 milligram for the 2 consecutive days thereafter. So it's 1 gram bolus, 500 milligram at 12 hours, and then 500 milligram over the next 2 days. Do we have evidence for this? No. Like Abhay, there are some things where experience looks at rather than evidence. But if you're going to use the conventional, mind you, contraindications are polytrauma, contraindications are elderly patients, and the ones with complete SCI, which has no role. Steroids have no role in them. Also, relative contraindication, poorly controlled diabetes and kidney diseases. So you have to be very careful. Steroids are a wonder drug, but you can't misuse them. Once you finish with steroid, then you look at diagnostics. There was this dilemma, what to do now? Radiology, we know 30% of the time misses a fracture. It either underestimates or undetected. But the question was, do we do the loading radiographs for everybody? Now that's important because standing and sitting position radiographs gives you much more knowledge. A standard 7-degree average increase in kyphosis happen from supine to sitting or standing. And if it goes beyond 20 degrees, it clearly shows you that there is possibly a posterior ligament complex injury. So it might not be possible in all patients. For example, if you have neurodeficit, you're not going to make him forced to stand up. Or if you've got somebody who's in severe pain, you're not going to force him to sit. But if you can, it gives you more data than what a standard radiology will give. And I think that has to be kept in mind. So attempt either a sitting loading X-ray, even if you can't do a standing, if it's possible, mind you, you're not going to put the patient to extreme pain to get it. Now, this is very nicely seen in this diagram here. So 2-level contiguous fractures, but the moment this man sat up, you can see the amount of aggravation of the kyphosis there. Now, CT is kind of completely covered up and taken away most imaging that happens in a trauma center. It has sensitivity about 100%. It defines the vertebral morphology and the comminution better. The presence of a bony posterior wall fragments in the canals is well documented, and also indirectly does give you some data about the PLC or the posterior ligamentous complex. Its biggest USP is that with a single screen, you can look at the head, the neck, the chest, the abdomen, and the spine. The problem is the radiation associated, and we all know about it. What about the MR? The MR can provide you with data which are disco-ligamentous in nature. So you want to know whether there is a discal injury, a ligamentous injury, the MR is much better. Occult fractures, which is extremely important. You might do an X-ray, completely miss a fracture because it's just showing an initial sign of edema there, which can be picked. And obviously, if there is neurology, you know about the spinal cord injuries more, including epidural hematomas, intramedullary hemorrhages, and other things. In an osteoporotic spine, the MR stands out purely because it tells you which one is old and which one is new. Most times you end up getting confused with an average X-ray on even in CTs for that matter. It also gives us the location and severity of the lesion. It indicates the cause, the cord compression, and most importantly, it is extremely useful in managing incomplete spinal cord injury. Also, a certain group which we miss, what we call as the scivora, which is spinal cord injuries without radiological abnormalities. Classical in a whiplash injury in the neck, right? You might have a problem, but at the end of the day, when you look at the neurology, the X-rays don't show anything. MRI stands out because it documents these kind of injuries which the others can't. A last word on whether you will do an EMG, NCV, SSCP. One of the questions the patients are going to start to ask and the relatives ask in a complete paraplegic is that, is this patient going to have a potential to walk? They might not ask you at that stage when the trauma happens because they are all in hope, but 6 months down the line, 3 months down the line, when nothing is happening, this is the time where they start to ask you questions of possibility in recovery. not a bad idea to document the EMG NCV in SSCP in traumatic spinal cord injuries. It can help you possibly give, with moderate evidence, mind you, the word is moderate evidence, the chance of subsequent recovery. It is not done at the moment of the traumatic incident. It can be easily done at 2 or 3 weeks after the injury. So it doesn't need to be done immediately after the injury has happened to document. So these are some diagnostics. Yes, sir.
सर जब पेशेंट को समझाना है तो how do we include in our talks कि वो moderate evidence है when we tell patients?
So correct. So one of the reasons is you kind of assess how the relatives and patients behave to you. Some of them have, not even bothered what surgery and when you're going to do. They'll first ask you, "Mera patient chalega na?" And obviously it's coming with concern, and I think empathy is important at this stage. You tell them that this is the problem, these are the things that we need to do, but if you want to know what is the possibility index, ये जांच बिल्कुल कर सकते हैं जो हमको डॉक्यूमेंट कराएगी कि आपकी बेसलाइन इंजुरी की इफेक्ट कितना है. उसके बाद अगर 6 महीने बाद अगर इंजुरी न हो, we at least have a baseline SSCP or an EMG NCV to show it. Now this is very argumentative because you might say, you are saying immediately na karo, surgery ke baad 2 hafte baad karo, because the neuropotential of recovery in a spinal cord injury kickstarts at 3 weeks. So anything that's done before that has the ability to show us a documented evidence. So agar doubt aaye aur aapko lage aapke paas facility hai, karaiye, na ho, don't bother. Don't even mention about it. Because say if you're in a place where you have no access to an EMG, NC, SCP, don't mention it to them at that stage as a part of the diagnostic procedure.
Thank you, sir.
No problem. So we'll go ahead. Now I saw some classification dilemmas. Now the problem in classification in spinal trauma, and I can bet hamare sab, when we got trained, oh God, abhi AO aa gaya. I know myself, I've said that ye kahan se aa gaya ye AO. The problem with classification, it goes to 2 spectrums. एक है scientific inter-observer communication. For example, if I want to tell Nitin that I have a fracture, क्या करना चाहिए? अभी के ज़माने में you have the WhatsApps to send the images and tuck, go ahead. Let's say 20 years ago, when somebody had to convey on a telephonic conversation कि ऐसी प्रकार की fracture है, to get the inter-observer communication better, so that Nitin or somebody else understands what I am saying, classifications were made. The problem is they got very complex, lot of numbers, lot of digits. And the other group of classifications which make you clear, you have this in place, iske liye karna kya hai, which is practical treatment oriented classifications. So we'll look at something which almost tries to get the balance. And that's where we'll introduce the topic of classification. So simple rakhne ke liye, somebody asked me the TLCIS or whatever the names are. This is what the classification is about. So I think next 5 minutes, all of you all focus. Morphological classification. So the first question you look at the X-ray or the CT or the MR is to say, this fracture is type A if the anterior structures collapse under compression, which is there. The anterior structures are collapsing, everything else stays intact. It's a compression injury. Obviously, upar se or niche se there is a compression force. The second one is type B, where the posterior or the anterior tension bands are broken. So this is not confined to the anterior, it's the tension band. The ALL, the PLL, the PLC, all of them are involved in this, and therefore it's a tension band injury. Ye normally distraction mein hoti hai, not so much in compression. And the third is all the elements are involved. So it is actually dislocated or displaced. So A is compression injuries which happen in the anterior structure. B is failure of the posterior and anterior tension bands, and C is where sab kuch toot jati hai. Are you all with us? One of you all can say yes.
Yes, sir.
Okay,
Yes,
great.
sir.
So now we go to the next. हाँ बोलिए.
सर जैसे सर पटेला होती है,
हाँ.
तो पटेला टूट जाती है तो बेसिकली क्वाड्रिसेप्स के मोड़ने से पटेला डिस्ट्रैक्ट होती है.
बिल्कुल.
फिर उसमें एक टेंशन बैंड फिगर ऑफ 8 लगा दो.
करेक्ट.
तो जब वो फ्लेक्स होती है तो वो पटेला को भी कंप्रेस करवाती है.
करेक्ट.
तो सर ये टेंशन बैंड है, तो सर ये प्रिंसिपल सर कैसे लगता है स्पाइन में लिगामेंटों के साथ?
चलो तो उसके नेक्स्ट स्लाइड में अपन वो देखेंगे. तो आपके पास जब इंजुरी आए, द फर्स्ट क्वेश्चन यू विल लुक इज दिस फ्रैक्चर डिस्प्लेस्ड और नॉट. तो पहला प्रश्न जो अपने आप को आप पूछेंगे कि ये डिस्प्लेस हुआ है या नहीं हुआ है, दैट्स द फर्स्ट क्वेश्चन. अगर है, then you don't need to argue. In the algorithm there you can see clearly कि ये ट्रांसलेशन इंजुरी है. दिख रही है आपको टाइप सी ट्रांसलेशन. इसमें आर्ग्यूमेंट्स नहीं है, डिस्प्लेसमेंट हुआ है तो ये ट्रांसलेशन हो गया टाइप सी. द नेक्स्ट क्वेश्चन आप जो पूछेंगे कि अगर समझो डिस्प्लेसमेंट या डिसलोकेशन नहीं हुई है, हैज इट अफेक्टेड द टेंशन बैंड एरिया आइदर द एंटीरियर और द पोस्टीरियर. अगर ये प्रश्न आए कि yes it is involved the anterior, then this is what we call as a hyperextension injury, which is seen as the B3. Okay, so this is discal level पर आपकी hyperextension injury हुई है जहां पर ये anterior tension band break हुई है. So the ALL with the disc is involved and therefore it is a hyperextension injury. This is B3. If you say नहीं anterior तो involved है ही नहीं, posterior involved है, so posterior tension band is involved, anterior involved नहीं है, then there are two forms, दो type के. Posterior tension band जब involved हो, दो किस्म की हो सकती है. एक वो जहां पर आप osteoligamentous disruption है, उसका मतलब upper end plate involved हो गया, disc involved हो गया, PLC involved हो गई, जिसको osseous and ligamentous दोनों involved है. तो यहां पर आप देखिए कंप्रेशन फ्रैक्चर हुई है लेकिन पीएलसी लिगामेंट इन्वॉल्व हुई है. दिस इज द B2. सो व्हेन योर क्वेश्चन सेज दैट टेंशन बैंड इज इन्वॉल्व, पोस्टीरियर ऑस्टियोलिगामेंटस इन्वॉल्व है, इट बिकम्स अ B2. नाउ द थर्ड वन इज जहां पर नो लिगामेंट इज इन्वॉल्व, इट इज ओनली प्योरली बोनी, इट इज अ मोनोसिगमेंटल ऑशियस डिसरप्शन जो आपको यहां दिख रही है, व्हाट वी कॉल एज ट्रांसऑशियस, जहां पर आप देख सकते हो ऑल इन्वॉल्वमेंट इज बोन बॉडी एंड इट इन्वॉल्व्स द spinous process, it involves the facet, the pars, and this one is what you see in chance fracture, which you see normally in what? Ankylosing spondylitis and all those conditions. So this is B1. Are you all with me here?
Yes, sir.
Yes, sir.
Okay, so we go next.
Yes.
Next question जो आप अपने आप को पूछेंगे, टेंशन बैंड तो इंजर्ड है ही नहीं, so अगला पार्ट ऑफ द बॉडी, आई मीन वर्टिब्रे जो इन्वॉल्व हो सकती है वो है बॉडी. सो द नेक्स्ट क्वेश्चन इज बॉडी में इंजरी हुई है कि नहीं. अगर बॉडी में इंजरी हो, मोस्ट इंपॉर्टेंट जो अब है वो ट्राइंग टू आस्क यू इज यू लुक एट वेदर द पोस्टीरियर वॉल हियर इज इन्वॉल्व्ड और नॉट. अगर ये पोस्टीरियर वॉल इन्वॉल्व्ड है इस बार, जैसे आप यहां देख सकते हो इन्वॉल्व्ड है, नेक्स्ट क्वेश्चन इज डज इट इन्वॉल्व बोथ द एंटीरियर or rather the superior and the inferior end plates? If the posterior wall is involved and superior and inferior end plates are involved, this becomes a complete burst. So question is the posterior wall involved first? Agar hai, is both end plates involved? Agar aap yes bolo, this becomes A4, which is complete burst. The next is जब एक एंड प्लेट इन्वॉल्व है, दोनों नहीं इन्वॉल्व है, यू कैन सी पोस्टीरियर वॉल इन्वॉल्व बट वन एंड प्लेट इन्वॉल्व, देन इट बिकम्स A3, which is an incomplete burst. Are you all with me here?
Yes,
Yes,
sir.
sir.
Yes.
Okay, so then you go ahead and say अगर vertebral body involved है ही नहीं, उदाहरण के तौर पर you say the posterior wall involved है ही नहीं, जैसे आप इधर देख रहे हो, and both end plates are involved. So there is an end plate involved above, an end plate involved below, but posterior wall being intact, this is a split or what we call as a pincer fracture. A split or a pincer fracture here. Whereas if you say both end plates are not involved, only one end plate is involved, posterior wall intact, this becomes a true wedge compression fracture, which is the commonest injury we see. समझो वर्टिब्रल बॉडी भी इन्वॉल्व नहीं हो.
One sec, sir.
Yes.
Sir, what is difference between incomplete burst and wedge compression then?
Sure. So that's a very good point that somebody asked me, that what is the difference between incomplete burst and wedge compression involvement of the posterior wall of the vertebral body, which means you have no involvement of the posterior wall of the vertebral body, and it only is at the upper end plate, as you can see here. Can you see that?
Yes, sir.
So this wall is intact, it becomes wedge compression. This wall is not intact, that becomes an incomplete burst. Have I clarified that?
Yes, sir.
Yes, sir.
So the next you go is no body is also involved. That means kahin na kahin ek thodi spinous process, thodi bahut limbus fracture, ya transverse process, something involved. They are the non-structural minor fractures, as we call it, which is A0. Okay. So since you have all gone through this, let's go through some. Before that, go into that. So once these are aligned, there are point systems that are put in place. So the compression fractures from A0 to A4 have this numbering. The tension band injuries have points from B1 to B3 with 5, 6, 7, and the translation is given 8. But ये complete इसीलिए नहीं होता because there is one more modifier, which is what we call as the M. Now, what is this modifier? There are some scenarios जहां पर अपने को tension band wiring की injury का कोई determination नहीं है. For example, MRI हुई नहीं है. Or there is a scenario where there is a bony injury, but the possibility of the ligamentous insufficiency we are not sure about. When that comes, put it as M1. Whereas M2 is where there is a comorbid condition. And what are the comorbids here? Ankylosing, dish, hyperosteosis, osteopenia, burns over the skin. These go into M2. Okay? So when you're not sure about the tension band injury, the modifier is M1. When you know of a sure shot documented comorbid condition, it becomes M2. Now, I'll try to clear off the doubts by taking a few examples. So let's look at the first example here. Okay. Now, when I look at the first example here, I'm trying to look at the fracture that I've put in here. So now I'll do the first one. I like you all to be involved in the next one. So I start looking at this fracture. I suddenly find, is this displaced or dislocated? I say no. Therefore, I can just forget about C. Then I go back and ask a question, is the tension band injury happened? And how do you know that? Where you see the spinous processes, the gap getting extended or increased. So the gap is constant in all areas, not increased. So tension band be involved nahi lag raha. Third, vertebral body involved hai? Yes, it is involved. Is your posterior wall involvement there? Yes, it is involved. Is both end plates involved?
No.
Why not?
No, sir.
Why not?
No, sir, because
Inferior end plate.
carry on, please.
So what do you think? Posterior end plate is lower end plate is involved or not? No.
No, sir.
Correct. So it is an incomplete burst. So when you name it as say, name the vertebrae first and name the type. So this is a T12A3. Okay. You agree with me?
Yes, sir.
Okay. So Gaurav, since you said yes, sir. Now tell, what are you going to talk about this one? What's your assessment of this one? Use the algorithm on one side and see how it works.
Sir, this is not displaced or dislocated.
Okay.
It's a dislocated.
So the tension
Are you
band,
sure?
the distance between the spinous process seems to be increased in this.
Oh, wonderful. Okay.
So this should be somewhere in B. Osteoligamentous, I cannot propose. Transosseous. B1, sir.
B1, okay.
And
isn't the vertebral body involved?
yes, sir. Vertebral body is involved, and this seems to be a complete burst.
So how do you want to give a nomenclature to this fracture?
So
First, you're going to talk about which vertebrae.
See, this is L2.
Okay.
B, B1.
Okay.
A4, sir.
Oops, sorry. So this is L12 because it's going, the PLC is going through the discal area, isn't it? So when you talk about an osteoligamentous, you have to involve the discal space. So it's L12.
Okay.
And then
yes,
I agree with what you said, B2, L2, A4. Got it?
Okay. Yes, sir.
Okay, Vaishak, let's go for you for the next one.
Yes, sir.
Okay, go ahead. Tell me about this one.
Sir, not a translation, not a C.
Okay.
I can see the posterior wall is disrupted.
Okay.
So with posterior ligamentous complex. I mean to say tension band is intact, sir.
Okay.
So with posterior wall involved and superior inferior end plates also involved.
Yeah.
Looks like a pincer type of fracture, sir.
Yeah. So now that's where the mistake I'll point out. A pincer is not a split or pincer if your posterior wall is involved.
Okay, sir.
So the moment posterior wall is involved, you can't put it as. How is it A3?
Complete both. Sorry.
So both vertebrae, no? I mean both end plates. So I knew you would bring the pincer, but the pincer is no longer involved when you have a posterior wall involved. That's gone. You know, got the point?
Yes, sir. Yes, sir.
Okay. Who else is left now? नितिन भाई चलिए.
जी सर.
हाँ बताइए इसके बारे में.
सर ये तो वही लग रहा है जो अभी अभी हुआ है सर. वेस्ट आपने किया है.
तो आप बताइए. लेट्स स्टार्ट विद इट. ये जो हमने डाली है आपकी कौन सी है बताइए. डिस्प्लेसमेंट डिसलोकेशन हुई है.
नहीं सर एक्चुअली ना वो मतलब एक फोटो इंसेट आ रहा है उसके पीछे छिपा हुआ है तो दिख नहीं रहा है.
ओके आई डोंट नो. एक मिनट.
हाँ अभी.
नो 1 सेकंड नहीं आ रहा है.
एक्चुअली यू कैन आप अपने कंप्यूटर पे वो निकाल लीजिए. सर का जो छोटा इंसेट रहेगा ना आप उसको नीचे ड्रैग कर पाएंगे.
हाँ यस सर.
हो गया.
यस सर.
हाँ तो अभी चलो.
हाँ
इसमें डिस्प्लेसमेंट डिसलोकेशन हुई है.
सर एक मिनट सर. सर इसमें डिस्प्लेसमेंट नहीं हुई है.
डिस्प्लेसमेंट नहीं हुई है. चलो तो आगे बढ़ते हैं. टेंशन बैंड इंजरी हुई है.
अब सर ये तो सर
सर
ये तो एंगस्पॉन टाइप का केस है तो सर इसके अंदर में तो
एक्सटेंशन टाइप.
यस
एंगस्पॉन है कि नहीं वो बाद में रखिए आप. क्वेश्चन सिंपल है. इसमें टेंशन बैंड इंजरी हुई है या नहीं हुई है.
यस सर.
नहीं हुई है सर.
नहीं हुई है.
एंटीरियर हाइपर एक्सटेंशन.
ओके हुई है कि नहीं हुई है. somebody else want to help? गौरव.
यस सर.
एक्सटेंशन टाइप सर एंटीरियर
हाइपर एक्सटेंशन.
हाइपर एक्सटेंशन इंजरी हुई है. ओके देन ओके
एंटीरियर में सर.
वर्टिब्रल बॉडी को इंजरी हुई है.
यस सर. इंफीरियर एंड प्लेट है. सुपीरियर एंड प्लेट. पोस्टीरियर वॉल.
डिस्ट्रक्शन ऑफ एंटीरियर लॉन्गिट्यूडिनल लिगामेंट.
हाँ so what does it come into?
टेंशन बैंड B3 सर. B3 L1 B3 और
and now most important it is probably an angspond or a dish. So what will you add to it?
M2.
Correct. So L1 2 discal level पे गया. B3 हुई और M2.
Yes sir.
Okay, now who's left to ask? Vishal Mishra, I can see a name. Vishal Mishra, you want to join?
Yes sir.
चलिए आप बताइए ये क्या है.
लेबल तो नहीं पता चल रहा है सर क्योंकि नीचे का विजिबल नहीं है. एनीमोर ट्राई करता हूँ.
नीचे का विजिबल तो मुझे तो है. I don't know. Harshal, you all can see? I'm not too sure.
Yes, sir.
Visible.
We can see the business area.
Yeah,
We
we
can
are
see.
able to see it, sir. Yeah.
We are able to see, sir.
हाँ
जी सर.
तो बोलिए. Obviously आप अगर आप ऊपर से if you draw a line through the posterior, I'll draw it for you. Say if I draw from here and draw a line from there all the way down.
यहाँ पे है ट्रांसलेशन है बट लेवल पता नहीं चल रहा है नीचे से कैसे मार्क.
ठीक है तो लेवल छोड़ दीजिए. मैं आपको बोल देता हूँ वो D89C. So which means this goes into the C group. So I think now when Manoj बाद में case present करेंगे, I hope you all kind of give us an answer about what the classification is. Okay?
Yes sir.
चलो, so the classification बाद में रख देंगे. We'll keep it aside. Now, most important, what added to the TLICS की importance is neurological science. उन्होंने involve किए. तब तक all the classifications will look at only radiology. They will look at X-rays. But when they added this component of neurological science, they put it as N0 where there is no focal signs, N1 where there was a transient neurology, N2 where there is radiculopathy, more relevant actually in cervical spines. N3 incomplete, N4 complete, and NX is, देखिए एक patient has got a head injury, intoxicated, under alcohol influence, you can't make an assessment, that's like an NX. And therefore, when you add all this up, like Manoj was trying to tell you, whenever you are less than 3, conservative or operative, this is the gray zone, we'll talk about it later, 4 to 5, and more than 5 was operative. So this is the classification for making an assessment of one nomenclature and possibly deciding whether you would conserve or operate. Now, what are the other variables important? Ye sab to hui baat. The other variables are biological age, bone quality, what is the activity level of the patient. किसी ने तो पूछा कि फार्मर है, माथाड़ी कामगार है जो गोनी उठाते हैं सर पे. Individual requirements of the patient. An IT professional will be totally different from what a farmer needs, correct? But ये सबके ऊपर is stability of the fracture. And what is definition of stability? ये जो बात हो रही है stable or unstable का, stable is if there is no neurological aggravation and no change in position. If that is not there, it is stable. For example, कई patients होते हैं जिनको आप sitting X-ray कराओ बैठाकर, they'll immediately say they've got a severe pain and pain going down into the legs. The moment they lie down, they get better, but the moment they try to sit up, it happens. That actually shows signs of instability, which means the moment you're loading, that fracture is tending to become more and more and more unstable, basically. So I hope I made that clear. A fracture is highly unstable if mobilizing that person threatens to neurological aggravation. This is the present definition of a stable or an unstable fracture. Okay, now most important, ये तो हुई theoretical. Now, अगर ये fracture आपके पास आ जाए, what are the approaches that you will take? When will you conserve? When will you operate? If you operate, what all will you do? That's what we're going to discuss in the next few sessions. Any questions at this stage?
No, sir.
Okay, so we'll go ahead. Okay.
It's been wonderful, sir. You can carry on.
Okay, so great. So now let's look at what an algorithm you all can sit and follow in a, in a clinic or some place where you get a fracture. This algorithm kind of makes things easy. I'll go to each of them separately. Let's start with the first one. Minor isolated fractures. We all know about it. Transverse process, spinous processes, limbus fractures. What is a limbus fracture, Nitin?
सर मेरे को नहीं पता सर.
तो ये देखिए, ये जो भाग है यहाँ पर
जी,
वो भाग कभी कभार with a sudden avulsion comes out. यहाँ एक क्रैक दिख रही होगी आपको
जी.
That's a limbus fracture जो बिल्कुल मिस हो जाती है because it's not so important. आप शायद देख भी नहीं रहोगे. ये पेट स्कैन में आपको दिख रहा है कि इनकी स्पाइनस प्रोसेस इन्वॉल्व है, ये ट्रांसवर्स प्रोसेस. Now the problem with these fractures are they are nagging. Patients are never happy. They keep coming at 6 weeks, 8 weeks, 10 weeks, especially the transverse process ones, because they are the ones in any activity that they do, unko darad hoti hai. If clinically it fails, one of the options is to give you actually a local block. Orthopedic wale jaise dete hain na intraarticular, a local block sometimes help, but most times they get better. So nothing much to be done iske liye. But the most exciting part is the burst fracture. So this is a big algorithm. मैं इसको split करूंगा, लेकिन I think again a few minutes of concentrated hearing. The first question that you will ask when you see a fracture in burst is, क्या इस व्यक्ति को neurology है या नहीं है? If it is not there, then you start looking at the fracture construct, because the first question in a burst is neurology. So if there is no neurology, for example, this patient has full power in the legs, the next question you will ask is the posterior column intact? So that question that I asked you, is the wall intact? Is the compression which has happened in the vertebral body actually less than 50% of the vertebral body size or more than 50% of the vertebral body size? Second question that you will ask. And the third is the angulation that is created because of the collapse. Is it more or less than 30 degrees? These three questions you will ask when you look at the radiology. I'll go back again. Posterior column intact, that's the wall. Less than 50% or anterior compression involved or not, and less than 30% of the angulation. In this context, let's go and take it forward and let's look at it case by case. So this one, this is a burst fracture, you can see, which has happened. If you look at it, agar you go by the principles, the posterior column looks all right in the x-rays available, isn't it?
Yes,
You will
sir.
also find that the collapse of the vertebrae that's happened is less than 50%. Do you agree? And the
Yes, sir.
angulation also that's happening is less than 30%. So this goes classically into a
30%.
conserved disc. And why? Even at 2-year follow-up, this person, or 6-year follow-up, there is about 11-degree increase in kyphosis, which, as Manoj said, doesn't matter in functional recovery. This is one of our patients, obese. You can see how obese he is, but he's got full functional recovery. And that's because you followed this algorithm. The question you asked, neurology, nil. Posterior column, less than 50% anterior compression, less than 30% angulation. Yes. Is there many other multiple traumas he had? No, it was a singular fracture. And therefore, you just conserve. And literature also talks about, our own Dr. Rajshekharan talked in 2015, and not only Dr. Rajshekharan, so many of literature talks about conserved bursts that can happen. So this is one algorithm for a stable nil neuro conserved burst. What do? Strict bed rest for 3-4 weeks was suggested. Avoid flexion, sit up, spinal rotations, avoid weight bearing, bed rolling encouraged. But what the literature talks about is now, it's pain dependent activity. If somebody says I can walk up to the toilet on the 8th day, encourage. If somebody says I can do it at 16 days, encourage that. You look at what the patient needs. Use of pain medication judiciously. One of the biggest mistake is we thump them with pain medication, especially in elderly, come back with acute renal failures, or aggravated CKDs, diabetes going for a toss, ketoacidosis setting in. You don't realize that because your ultimate aim is to give pain relief, but you're going beyond what's acceptable. Third, core and back strengthening exercise with lower limb rehab. So this one issue that the longer you keep them in bed, you're going to have stiffer joints. Work on the lower limb exercises. Tell them that you have to strengthen the core. The core has so many exercises which necessarily doesn't need to be loaded, isn't it? You can be actually horizontal and still do it. And obviously the big Pandora box of calcifying treatment. I think we can look at it later. It's not important now, but calcium, vitamin D, whether to use bisphosphonates or not. I thought we'll discuss that once we come in to the section of discussions later. But these are going to be your probable tenets for managing conservative trials. But so let's look at the next case. Nearly similar, if you look at it. The CT also looks nearly similar. Not major angulation, not major collapse, less than 50%. MR also not greatly impressive. But the problem changed here because he had a bad acetabular fracture. He had actually pneumothorax for which ICDs were put with rib fractures. So here you're looking at it as a part of a polytrauma. Obviously, the other fractures are going to be handled. You don't want the mobilization or getting this patient out of bed getting hampered because your fracture is there. Fix it. A posterior spinal arthrodesis, as we call it. So in this, the algorithm is no neuro, still stable, but multiple trauma. Fix this one. So nearly 2 similar fractures, but different scenarios, and therefore we are giving it a different connotation, isn't it? Let's look at the third group. Now this one. Yeah, here the things start to change. The collapse is significant. Rather less than 50% here. Angulation, okay, moderate. If you look at the CT, probably not as much. But what matters here is we did a fixation here, which was 1 level above, 1 level below for this patient, purely because he had multiple other injuries, and we did it. And when you look at this, I thought the first 2 questions that people should ask me, how did you manage to just fix 1 level above and 1 level below? Did you not have a problem? Isn't that the first questions that you'll ask me? Fortunately, in the CT at 2 years follow-up, he showed fusion. But there are 2 parts after this that I'm going to discuss. One, is this a dictum? No. Why? Because we've had burst fractures. There's one lady which we'll never forget, admitted for surgery. We talked about the amount of compromise in canal that you can see, amount of angulation, the amount of burst that's happened. Actually was going to post her for surgery. But the next day, because of some medical reasons, diabetes, we had to postpone. Next day, we took her around and asked her, "Are you feeling better?" She said, "Yeah, I'm feeling better." And the accompanying person, they said that she even sat up for food. She had breakfast today. So just like Abhay said, he made to sit. Would you imagine making her sit for food? She was already made to sit before we even told her to. And because we thought that she was pretty comfortable, we said, okay, we'll conserve her. This went on for weeks. And at the end of the day, that's the function she has at 1 year follow-up. And even look at the X-ray. We know there is an orthopaedic fusion that's happened with a significant collapse, like an alligator mouth, as we call it, but it's an inherently stable one. So all bursts doesn't need surgical interventions. That's again what I'm trying to tell you. Some of our fellows tell us burst fracture, which is this concept that you need to fix every one of them, not particularly. The second point, which I thought you will say, is stabilizing short segment, like the one I did earlier. Now, I've been lucky in a few cases that I get away with this, but not all of us are. Because if you do this, the implants break. Why? Because all vertebral fractures collapse as they heal. They don't maintain the integrity. You see, even the ones which we conserve, they heal, but they heal with collapse. So your implants might give away, and that's when in 2018, Vaccaro suggested that you should try putting one pedicular screw at the fracture level itself. So one modification, if you're going to fix, is to try to put one at the fracture level. These need not be long constructs. A short screw which just crosses the pedicle. The intention is to actually prevent a collapse. And that's something worked, and I've used it extensively over the last 4 or 5 years, and it's worked well. In osteoporosis, the problem adds up because the same thing that you did can still collapse because the disease is a problem. So in these groups, you can actually try to stabilize it anteriorly, which is said by a meta-analysis done by Kremer, where you do cement augmentation in the front and fix a short segment. So 2 scenarios in burst, one we conserve and one we modified our technique to prevent implant failure, either because of metabolic reasons or biomechanical reasons. Now we're going to burst with neurology. Are you all guys with me? If one of you all can say yes.
Yes, sir.
Yes, sir.
Okay. So keep asking me if there is something that's boring and if there is something that you all didn't understand. So the neurological deficit group is where you ask the question, is the guy coming within 48 hours or guy coming after 3 weeks and 4 weeks? And that will decide on how your approaches are going to be. So let's look at one of them. This is a person who had a fall from a bike 10 days ago, was neurocompromised to a stage of grade 3 in power. You can see the significant amount of compression that he has here. You can see his little myelomalacic changes that are happening there, and canal compromise more than 50%. So neurology was but natural. But the problem was he's got a massive wound in the posterior skin area, exactly at that area. He fell from a bike and he got pulled along the bike. And you can see the kind of, what we call as the skin status that's there at the back. We did an anterior for this one. Now, I haven't done too many anteriors, mind you. This is probably almost 9 or 10 years ago that I've done. And you can see I don't have the full X-rays even. I've just got a CT in place. But why I wanted to bring things is that the algorithm here is that the fractures happened less than 48, happened at 40, and he needed to be anteriorly decompressed and stabilized. There were no great posterior column disruption, and therefore we need nothing to be done posteriorly, just a probable brace that I used at that time helped, purely because there was a wound in that area. So you can see the wound changed your approach. Because this wound's going to take days, weeks to get better, and you don't want your surgery to be spoiled because of that. Now, this one's interesting because it's a 27-year-old laborer. He's a guy who lifts these 80-kilo jute sacks. We call them mathadis in Maharashtra. They shift gonies from one end to the other, almost 8 days post-fracture. And you can see it's a significantly comminuted fracture that's happened there with significant amount of core injury. I think if I remember right, he was grade 2+ or 3 in power. Now, why did I do an anterior reconstruction here? The answer is you go back to the algorithm. If you look at it, he's got significant amount of collapse, which has happened. He's got significant amount of comminution in the vertebrae. So consolidation, however, the X-ray looks very innocuous, but look at how the CT looks. A little amount of posterior ligament is. So and a laborer, imagine 27-year-old laborer who's uneducated, he probably can't do a job anymore. Be aggressive here. You probably want to do an anterior and a posterior reconstruction. Somebody might say, "Itna sab karne ki kya zarurat thi?" What tweaked my thought process to doing more aggressive? His job profile, his age, and the amount of comminution that has happened there. So here, when you look at it, I did an anterior stabilization. He had a significant posterior column disruption, and therefore I did a posterior stabilization also. I heard some noises anyway. Somebody wants to ask a question at this stage? Okay, so I'll go ahead. Bronson in 2018 in a meta-analysis said that late onset kyphosis can be improved by doing an anterior reconstruction. So in certain cases, do not shy away from the fact that you need to anteriorly reconstruct. This was what done by an expandable cage. I did this from behind, so no approach from the front. It is all done from behind. Thank you. Okay, let's look at one more. 50-year-old road traffic accident, neuro weakness. She was on, I think, steroids for some asthma or something. I don't remember what it was, some skin disease. Comminution here, not as much, but osteopenia. Here we use the conventional old sublaminar wires for fixation. So questions you're going to ask me, why this? One, because osteoporosis. Made me think differently because a screw is like putting a nail into a wall. Would the nail going into the wall be stronger, or a wire or a twine going around the wall or around the pillar be stronger? It has got extra osseous hold. So in an osteopenic fracture, it helps. Second, it helps some amount of collapse inherently, the construct of sublaminar wires, which is useful in an osteoporotic fracture. And third, most importantly, the only downside about this is you probably go more segments than required. We've gone 3 or 4 above and 3 below. So in a predominantly osteopenic fracture, in the dorsolumbar junction, as we are looking at, sublaminar wires are brilliant for osteoporotic fractures. So I think one kind of implant that you can use, the algorithm goes that way. We did a TPD here. What about fracture dislocations? There are no questions here that all the surgery here that you're going to do is for stabilization, essentially for not neuro recovery. It's to rehabilitate him, go aggressively, fix 2 levels above and below, and anteriorly either with graft or cages as when and required. Be aggressive here because rehabilitation is important here. What about compression fractures? One question that you are going to ask yourself is more than 50% or less than 50% collapse? So like this one here, which is I think 5, 4, 3, 2, 1, L1 compression fracture. When you make him sit, this one here is a loading X-ray. But as you do a CT, you see a void, not the true cumulus, but you can see a void. And imagine we could get in as much as this much cement in by doing a vertebroplasty. You can see a little streak here, a little streak there, not the best, but you can reconstruct the anterior column well. So a compression fracture, more than 50%, you could think about a local, very specific, this can be done under local anesthesia or even sedation for that matter. But if it's less, I mean, the compression is probably not as much, less than 50%, completely conserved. This guy was 136 kilos. You can see it has how he is, and great function, and he's about 4.5 years now with follow-up with us. Chance fractures are important because these are the ones where you have complete 3-column injuries that happen. Most of them happen through bone, but some of them can have significant soft tissue involvement. So like that, in a significant soft tissue involvement and bony involvement, you can see that how a classical, chance, just fix it, stabilize it, and they do well. Let's have a few special considerations and points here. When do we operate? So in 2022, there was this very important and lovely meta-analysis which was done as to when to operate with neurology, without neurology. So without neurology, obviously there is this concept that you might try to wait and watch. But if you want to operate, the best results come within the first 72 hours. Because the longer the stay tends to be, the longer the problem set in. There are scenarios where patients, actually women, have had urinary tract infections, which has really got bad, or chest infections, which has delayed your surgery because you inherently didn't start off. So the general consensus is, in a fracture without neurology, best results 72 hours. Whereas the fractures with neurology, 24 hours. Now, this is after a meta-analysis of multiple papers done. There are red herrings in this, but this is what the general consensus is. But again, going back, maintain blood pressure from the site and time of injury to the ultimate intervention. Whether we should decompress or not. Now, this is another argument that keeps coming, that how much to decompress and where to decompress. I mean, what is considered a case where you would decompress or not? The pro-canal decompression guys would say adequate decompression, because somebody else will comment on the post-op MRI, kuch kiya hi nahi, decompress hi nahi kiye. That is a feeling that all of us have. So you say, no, we should decompress. What about against? Say, imagine you have a massive dural injury, CSF leak, roots, if I might be rude, spaghettis all around. The increased likelihood of meningeal infection, higher chance of neurological worsening or whatever. No gains. Why are you doing all this? These are the guys who are against canal clearance. What is the general consensus here? One thing you have to remember, canal clearance necessarily doesn't mean neurological improvement. So that's a very important word here. Second, you go for clearance if partial deficit with definitive radiological signs of compression. So the patient is not grade 0, but the X-ray, MR and CT show good compression, which can be validated. Go ahead. And it's easily possible intraoperatively, not a messy one. The second one is avoid canal clearance if you have significant cord damage. Clear transection of cord, I think don't even bother, stabilization is good enough. Or there is an insignificant compression, like a scenario where you have, say, let me argue and say a B3 kind of a fracture. No involvement neurology, you just fix and come out. So there's no question of compression there. But the biggest problem, all of us will agree, is this gray zone. The gray zone is whether ligamentotaxis helps. So concept is you're actually kind of bringing in the posterior longitudinal ligament to press the fracture fragments ahead and achieve indirect decompression. The people who talk about going ahead and decompressing are the ones who say there is what we call as a buttoning phenomena. So what's a buttoning phenomena? If you put your buttons in your shirt, you remember there is this slit through which you push your button forward, isn't it? Are you all there or slept off?
Yes, sir.
Yeah, sir. Yeah.
Sure.
Yes,
So
sir.
if you
Yes,
look
sir.
at, if you have the buttoning area, jahan par aap button dalte ho, PLL sometimes can act like that hole. So in your ligamentotaxis, sometimes that fragment can actually come out from the breach of the PLL. So the fragment actually comes out into the canal and doesn't stay. So all ligamentotaxis effects of stabilization, which we call as indirect decompression, may not work. So that's the gray zone. If you ask any of us, do we have an answer? No. The golden rule or an answer I can give is, if you believe the neurology is significant, it is better to err to decompress rather than be worried at the end of the night and sleeping and not sure whether you did the right job. So I think err to decompress. What you choose, anterior or posterior, I think is a surgeon's choice. More or less dependent on the kind of fracture. But most importantly, if you don't need aggressive anterior reconstructions, we can easily get away with posterior approach. It's an approach we are all comfortable with, surgeon friendly, if I might call it. It's the only group where you need excessive anterior reconstruction. I told you, we did one anterior reconstruction completely from behind. With the kind of implants and instrumentations you have, the need for anterior approach is getting lesser and lesser now in modern practice. Short segment fixation. So how is your construct going to be? Short segment posterior if anterior reconstruction is unnecessary, or you're actually doing something anteriorly. So if you look at that fracture where I had done an expandable cage, I had a short segment fixation from behind because that's good enough. So when you don't need an anterior reconstruction, or you're already going to do it, that's where you do a short segment posterior. Use the pedicle of the fractured fragment, like Vakaro said. Long segment fixations is when you're only posterior 2 levels above, below for a pedicular screw, 3 above and below if you're osteopenic, and you are not sure about the hold, or when you're going to be using wires 3 above and below for minimum for sure, you should augment the cements with screws if you're in osteopenic. Combined anterior and posterior is in significant instability, which needs anterior reconstruction. I know WeAreSpine is going to have a session on osteoporosis sometime for sure, but I'll just run through these topics. Problems with osteoporosis is that it is trivial trauma, bone fragility. So you have the best screws, but poor bone. Screw bahut achhi hai, lekin diwal ki cement kharab. So what is the point? Even after all these, you might keep falling further. There are risk of falls, poor musculoskeletal biomechanics. Failure of conservative trials happening is much more in this group. And when you operate, you decide to operate, bone quality, morbidities, mechanical failure, and adjacent level are your problems. So in osteoporotic fracture, balloon kyphoplasty or vertebroplasty helps. It's a good adjuvant or even a primary treatment. And if you are good at MIS, try to reduce the tissue handling and reduce the morbidities, like one of these that we did. So those are consideration for osteoporosis. The last point, neuro recovery is something that you should never promise. And we all know that. Our teachers have taught us that don't play Superman here. And because you've had a wonderful post-op X-ray and an MRI to show or a CT to show, because an aim in surgery is to decompress, stabilize, and early rehabilitate, not to guarantee neuro recovery. We were lucky enough, and I thought we'll share this here, to do a small study, which we did, that we found that in dorsolumbar, thoracolumbar traumas, which involve the cauda equina area. We know the cauda equina area extends between the D12 to L2. Intraoperatively, if you find a dural breach, so you're decompressing and suddenly one of us gets scared and suddenly CSF comes and you see some rootlets there, it's actually a good sign. Now you will say why? That we found that the ones in which there is no dural breach actually recover lesser. The ones in which dural breach happens and there are rootlets or spaghettis, if you want to call them, they sometimes actually recover better. Now, the answer to this is what we learned from our small series, which we presented, is that dura mater is like a mother. Mater in German means mother. Dura mater is protecting the rootlets. So when you have impact where the mother bursts, the rootlets are saved, the kids are saved. When the dura mater is intact, it is not broken, the impact gets transmitted to the cauda equina and rootlets. So when the breach has happened, which has happened due to, not due to surgery, but due to trauma, the chances of recovery is actually better. That's something we found. So remember, just because you know to perform surgery, don't take that as the criteria. Don't take away the indications. Opt conservative, but very important in this modern era of practice, not at the cost of patient's disability and expectations. It's, I think, very, very important. We're trying to tell a patient, nahin, theek hai, thoda aur sahan karo. Keep the options open, give them the options, and they accept, go ahead and do it. Don't stay away from it. Stay by the principles, because most times it gives you good end results. Medical practice, mind you, is an amalgamation of evidence peppered a little bit with experience. If you go to literature, everything will be justified. So be case specific. So what is your case is your case. Have a multidisciplinary approach. Clinico-radiological correlation is very, very, very important. And especially in whiplash injuries, there's nothing much in the bone. Gross neuro, don't need surgery, follow that. And keep your patient in the loop. Every step from diagnostics to surgeries has to be discussed with the patient clearly with prognosis. I think these are my words. Thank you.
Thanks, Raghu. I think that was very, very composite, and that opens up, opens up the field for a lot of controversies and questions.
Yeah.
And I can see some hands going up. Who's the first to take the shot at the question?
Yes, sir.
Do you want to unshare your screen, Raghu, so we can see everyone on the...
Yeah, one second. Yeah, sure.
Sir,
yeah.
What is your therapeutic protocol for whiplash injury?
So I think I would probably say, I think that's probably one of the reasons where you use steroids judiciously, but whiplash injury has two components to it. One of them actually is the edema in and around the cord, which is something that we can use to reduce and probably reduce the cascading effect that can happen through, whatever has to happen, phagocytosis and all those things. So steroid helps for sure. I told you, generally I have this protocol that I've maintained. I don't have evidence here, which I have to be very clear. I give a gram at that moment, 500 milligrams at 8 to 12 hours, and then repeat it for the next 24 and 48 hours. Barring that, I actually get very aggressive with rehab. The more earlier we start to rehabilitate them more. For example, if it's cervical spine, find a good corset or a collar or whatever you can use and be very aggressive in rehabilitating them. I don't do anything more than that. I don't know what the other faculty, Abhay and Harshal and Aditya, can talk about.
Excuse me, sir.
Shashank?
Yes, sir. I have a question, sir. As you have showed your cases where you have done a short construct stabilization of few of the patients. So does the length of the screw penetrating the vertebral body makes a difference in that case?
So I don't think I've done it intentionally. I generally try to get the best length possible. Sometimes I've actually even erred to get the other cortex. It's not intentional, mind you, and D12, L1, L2 probably not the best area to try to be bicortical in nature, and we know for anatomical reasons. But yeah, the construct above and below, I try to make it as long. Nowadays, I actually try to go to the antero-superior part of the vertebrae. So try to, rather than keeping it parallel to the end plate, look up there into the antero-superior part. That's something that I do. The middle screw in the fracture, I never try to go beyond the posterior 1/3 of that vertebrae, because in that area, it starts to get very messy. So I just kind of, my criteria is just to go across the pedicle in the fracture segment. I hope you understand what I said, basically. Yeah.
Yes, sir. So, and usually what we see, like, to get a picture which is very perfect as a fixation, so we want the screws to be parallel. So is there any specific study that it should be in not a parallel direction or in
No,
some,
so I think there is some study that's come out. I'm not too sure if you ask me randomly, but I think there is a talk about going to the antero-superior part of the vertebrae, which probably gives you the best hold. I'm not too sure. I don't know the authors, but I randomly remember something. Harshal or Aditya. Harshal, I think there is
we'll
one.
go through, sir.
Yes, sir. So divergent screws are better. That's what they say.
Yeah, okay. It's like yeah.
The upper one's looking up and the lower one looking down.
Looking down, yeah, they talk about the triangularization effect of a screw, which.
Yes. Thank you.
Even I would like to make one comment here. In osteoporotic fixations, wherever we are using pedicle screws. So intentionally, in such cases, I always try to take opposite cortex purchase.
Yeah.
So just for my mental satisfaction, because I feel that if at all the opposite cortex, if I have taken purchase, the pull-out point of view, it will be a strong construct. And also one more thing is I always try to put crosslink at the end of my construct, just to make the construct more stronger and the parallelogram effect. So that one point I would like to.
Sure.
The long construct, to prevent to protect it from axial loading, I think the transverse connector can do well, but for a shorter construct, I typically avoid it.
It's not for a short construct, it's for long construct. Yes.
Yeah.
Yes. And also one more point.
Which is what the wires and the loops does, isn't it? You get two transverse connectors at the two ends of the construct. What can get better than that?
Absolutely. And one more thing, wherever, if at all we are trying to combine our pedicle screw fixation with, I mean to say, a short construct if you are aiming for, especially in osteoporotic fracture, then don't just do single level one above below. What sir showed in one of the cases where he has put short screw, or if at all, then supplement, or just don't do only isolated vertebroplasty.
Yeah.
Don't do only vertebroplasty. It has to be supplemented or supported with one level above below short fixation at least.
Yeah.
Raghu sir, I want to ask one question about in cases where we are trying to conserve the patient. Often these patients are elderly female. Means, if for example, if D11 or D10 level fracture is there, and we are trying to conserve that, we end up giving them Taylor's brace, but they are physically fragile. The
Yeah.
weight of that Taylor's brace itself is kind of too much for them. So
Correct.
how do you protect that, or how do you brace them, or what is your take on that?
So I think one tip which I have done for over a period of the standard Taylor's brace, which is available in the market, which is size based, you would rather do probably make a customized corsets for them, because the material that you use for the corsets customizes much less heavier than the standard Taylor's brace. The only problem in that is that in Taylor's brace, probably it is more rigid, and therefore you get probably a little better, whereas the customized braces might tend to be not as, because the patient takes the form as he wants to. You might have umpteen number of times seen that the customized brace, that thing is like standing out and he's just holding on to the straps there, which doesn't work actually. So I think I'll agree, probably use a customized brace as compared to rather than the standard, because like you said, they are fragile, they are already kyphotic. Most times it's difficult to get something which fits to them properly and doesn't serve the purpose what we're looking for. Yeah.
Sir, I would like to ask you once again regarding that dural. This one, sir, you had mentioned.
Okay.
Is it just in that level, or
no?
I'm so asking, is it just traumatic, or what if it is in a cauda equina where there is
no?
big disc or something?
Yeah. So we did this for only trauma. We did this for only in the thoracolumbar junction with cauda equina injuries. So we've not looked at the cord injuries that we've had. I don't know whether it's different. We've not looked at the pure roots. We've looked at the cauda equina area. So it's only trauma and only in the thoracolumbar fracture. So I can't comment anywhere beyond it. Fortunately, we've done. We've actually had series beyond that where we prospectively looked. We used to get a guide to look and say, "Chalo, isko improvement hoga ki nahi?" And then we prospectively look at 3.5 years. I think 3.5 years now, and we've been lazy to publish. So pardon me for that. But 3.5 years, we found actually it corroborates evidence. It is exactly almost as we saw in the retrospective study. So yes. So dural breach, sometimes the surgeons, orthopedic, oh shit, now you can see so many things happening here. No, you're worried, but it makes me smile always because it gives me a little more hope nowadays. So I think
sir, actually, my experience would be a little anecdotal, but before that, I would want to ask you a question. With a very large fragment sitting in the canal, but maybe not that significant neurology, would you decompress?
Yeah, now what is significant neuro? So this is what I said. This is this big problem of, there is some group who will categorically say that we'll just do ligamentotaxis fixed from behind, baki ka will just happen by itself. That's how they would look at it. Whereas some, I mean, you can include me in that some, is that the fact that the neurology is there, you feel that, would you like this person to be operated by you, not recover at 3 months, and then go to Herschel Bump, and Herschel Bump does an MR and finds that compression there. Yeah. So it's natural for us to be a little careful in the practices that we are. But I think I would put significant neurology. I can bet Abhay will come out and say, what is significant? But for me, anything beyond grade 3 and beyond, I would not ever think about not to decompress. I think that straight away. Where there is radiological evidence, mind you. So I'm not saying just like that, but radiological evidence, I would go ahead and decompress. Now, would that mean grade 4, you wouldn't? I don't have an answer. I think none of us do. I mean, I don't know if any of us do that.
No, because I put it up because last couple of cases where I actually went ahead, because I'm from the same lineage, I went ahead and did a decompression, and there was an extremely bad dural injury and rootlets coming out and everything. I was cursing myself. Why did I do it?
Why did I even bother it? I agree with you, Kamre.
But the anecdotal evidence is that patient woke up without any neurology. So for me, I think that proves the point which you're trying to make.
I mean, I hope so. It'll be multicentric study would be helpful. That is one. The second part of it was, and invariably you look at it, your dural leaks in a disc surgery or stenosis will go into a leakage from the wound. But your fracture spines, I can bet seldom it's leaked from the wound. You go back and look at all the cases. You probably found all the roots lying all around there, but still they've never had a wound leakage of CSF, have you?
True.
So,
Interesting observation.
In your
Yes.
study, have you repaired the dura or not?
No, I haven't. I actually haven't. So I have just left it as it is. It is just jaldi band karke satak jao attitude. Zyada karna nahi hai. It's something like that, I think. Yeah.
Perfect. Any other questions, guys?
Yeah, excuse me, sir.
Question.
Yeah, Gaurav, please.
Good. Sir, you showed that guidelines recommend operating on guys without a neurology within 72 hours.
Yeah.
And with neurology, preferably within 24 hours.
Yeah.
So, sir, should we not wait for the conservative therapy to give a chance for it to neurological recovery, or we should straight away jump in?
So your indication to operate is already done.
Okay.
So you have defined whether you're going to conserve or operate. Once you know this one needs surgery without neurology, your best results happen in the first 72 hours purely because if you keep them in bed for longer, most of them either end up with respiratory infection, urinary infections, your wound doesn't heal. So you're actually prolonging the misery of the patient. You get the point. They don't contribute in rehab. So in that then you get a plastic guy involved, and all these which you can avoid, get the first 72 hours. So if you decide that you're going to do it, stay by 72. It's not a decision whether to conserve or operate. That's already made. This is when to do it afterwards. Yeah.
And sir, one more question. Some tips regarding that contouring of the connecting rods, sir. Do we need to do that when we are in the transitional junction? I mean,
contouring of the main rod, you're saying?
Main rod, yes, sir.
Not the I think try being as anatomical as possible. I think that's the way to look at it. There are times you actually can't, you may not even achieve it, but try being as anatomically as possible, and put it in the normal dorsolumbar, whatever, sagittal alignment that you want to achieve.
Okay.
Basically, if your rod is trying to correct a kyphosis and you've not reconstructed the anterior column, you should be worried.
It'll collapse.
So if you're accepting a kyphosis, it's good to accept the rod in that position. If you're trying to correct the kyphosis, you better reconstruct the anterior column. Raghu, there's a consistent question from Pankaj.
Sorry, sir. I have not been seeing
the chat box. How do you prognosticate regarding neurological recovery? I think that's a social question.
Yeah.
So how can you give us your practice tip? So someone who's come with a complete para and someone who's come with a partial deficit of the conus region. I mean, how would you?
So actually, I blatantly kind of talk to them in the same way, because sometimes what tends to happen is that the complete para guys accept it more rather than this grade 1 or grade 2 guys, because there is this hope that it should get better. And the questioning effect on whether your surgery has been adequate or not are in this group more. Because the pair to heal hi rahe the, or to hilni chahiye. That's the attitude they come. Whereas in the complete paras, it's probably more easier because however you might say they have hope, the hope is not great and extensive. So for me, I would say I'm guarded. I have the same approach in both of them. Sometimes I think it's best to tell them that this surgery is not actually being done for neuro recovery. It's been done for getting him out of bed, participate in exercise regimen, prevent the complications that can happen. And if neuro recovery does happen, it's a bonus. I think it's not bad to be actually quite harsh in this, because you might not want to lose this patient surgically now, but you will have to probably answer his questions at the end of 6 months and year, which you don't have answers for. So I think very hard. I'm not saying harsh enough to make them feel bad, but I think put the realistic option straight away. So Nitin का उत्तर आप बताइए उनको कि चांसेस रिकवरी की बहुत कम है, सर्जरी की जा रही है, सर्जरी न्यूरो रिकवरी के लिए नहीं की जा रही, उनको उनकी कमर को मजबूती आए, उनको बिठाए, उनकी रिकवरी की पोटेंशियल को बढ़ाने की पूरी कोशिश हो, ऐसे अंदाज से आपको उनसे बात करनी होगी. मुश्किल है, बट आई थिंक इट इज इंपॉर्टेंट. क्लैरिटी बहुत इंपॉर्टेंट, क्योंकि मुख्यतः यही पेशेंट्स है जो 50 लोगों की ओपिनियन लेनी जाएंगी. बिकॉज आप तक सीमित नहीं रहेंगे, आपके दोस्त बगल में होंगे, आपके दुश्मन भी बगल में होंगे, सबके पास जाएंगे वो लोग पूछने. सो आई थिंक पहले से उसकी ठोस क्लैरिटी रख दे तो इट विल बी मच इजियर.
नितिन, आपके सवाल बॉम्बे वालों की हिंदी एटलीस्ट सुधार रहे हैं.
अरे शुक्रिया सर, शुक्रिया सर.
अच्छा, there's a question from Virendra. Virendra, go ahead.
Yes, sir. My question is to all the faculties. I have experience in paraplegia department where I used to work in the residency, and I have seen many patients of paraplegia with indwelling catheter and power zero, a quadriplegic patients. Do you have any experience of putting any electronic chips inside the spinal column so that it will be better? And another thing, if it is not possible, what is your standard protocol to decrease the infection and decrease the problems of these patients?
I think indwelling catheters should be done away with. You should no longer be using indwelling catheters for paraplegics, and everyone should go into clean intermittent self-catheterization. We've used the neuromodulator in the spinal cord on 3 occasions in my experience, of which one was for a post-traumatic paraplegia with phantom limb. I mean, it was an amputee with a paraplegia with phantom limb, and it worked beautifully. But I don't have the experience that I think ISIC in Delhi has, where they've used a chip to trigger the bladder. But I think it's just a new thing. Tausif, do you have any literature knowledge about this, using a chip to start bladder function? Is that what you're asking, Virendra?
So not only that, every aspect of a paraplegic patient and its family members who are passing through this condition a lifetime.
Yeah, I mean, neuromodulation is a question, whether you can do neuromodulation in the spinal, putting the electronic stimulators, and that helps spinal pain and neurological pain. But everything else is a huge social burden upon all of us, and it's up to us to encourage the family, try not to let them go into the hands of unscrupulous people who are doing stem cells, save up the money for rehabilitation, explain them, give them the connects for rehabilitation. We have 3 or 4 foundations which help occupationally reinstate these people. We have centers where they can communicate with other people who are paraplegic and see how they've done. So I think that's the way forward. It's a huge, huge problem, and I mean, we hope that nobody ends up with this.
I think I'll just add up and say, I think getting them to a source of income and occupation is extremely important. It gives them 2 things. One is this financial stability, which makes them confident. And the second one is their minds are occupied. It's but natural. आप देखो, आप एक दिन छुट्टी लेके, you sit at home, so many things to think about which you would probably not even thought about when you're going back to work. So occupation to keep the mind away from the thoughts that you don't want to, and second, make them financially a little more independent. It just brings a different thought process to all this group. The same catheter will not be an issue. Same CSIC will not be an issue if he's employed and he gets the monthly pay. I think that's where it made.
Maruti has 2 questions. One of them I couldn't follow, but one is that what do you do with a pure posterior column injury in the cervical spine, posterior ligamentous column injury?
So I think it's a whole new ball game. I don't think you can put the cervical and the dorsal lumbar in the same context. I want to believe that we'll have a cervical spine session later, Abhay, and I think Harshal, I'm happy.
This is the lumbar spine fellowship.
Yeah.
Join us for the next.
So I think we will discuss it, because it's a whole new ball game, and your concepts are very different from what you would do for a thoracolumbar junction. So I think we'll discuss it some other time. I mean, I have enough to talk about, but we'll do that later.
Yeah. So the other question is about hyperextension injuries, anterior so how would you plan the management?
Hyperextension. I don't think that's so much. No.
And
in hyperextension,
they're the most unstable injuries in the world. You have to be aggressive, and you have to be, ideally get a long posterior fixation, or sometimes a 360 also.
Correct. So most times a long, 3 to 4 segments above, below, probably the best. Or if you really feel, even put in some chip grafts in the front, if you really feel the gap isn't too big. Otherwise, you go full Monty and reconstruct it MTV.
How about we get into some cases with Manoj?
Yeah, perfect.
Get some more discussion going.
Manoj, you can get these guys to classify. So if they, at least some take-home message which they have got, it might be helpful. Okay.
Manoj, unmute and share screen.
Yeah. So I'll be just continuing with the second case, sir. Is my screen visible, sir?
Screen is visible. You can carry on.
Okay. So coming to the second case, we had a 36-year-old male who presented to us after a road traffic accident with GCS of 15 and there was local tenderness in the lower back. Neurology-wise, there was weakness in the bilateral L4 and L5 nerve roots and the goel bladder was affected. He presented to us with this X-ray. So can someone tell, will be able to classify according to AO or tell what type of injury it is, at least based on the X-ray?
L4C, sir.
Okay. So moving on to the CT scan, we can see that there is a fracture dislocation, sir, with fracture of the pars and there is subluxation. And on MRI, we can see there is a severe canal compromise at L4, L5 region. So what would be your plan in this case? Can anyone answer?
Anybody would want to take it up? I think who said who gave the answer? L4, L4C.
Gaurav.
Yeah, Gaurav. Come on.
Sir, I'd like to opt for a posterior decompression and long segment fixation for this.
Why long segment fixation, Gaurav?
I mean 2 above and 2 below, sir.
So from L2 to S1?
L2, 3, nah, the L5 and I would fix L3, 4 and if I can put a screw through L5, then L5 and S1.
L5 and S1. S1 also you want to fix?
Yes, sir.
So anyone wants to answer anything different apart from this? Because we are dealing at lumbar spine and we know that we need to save levels to keep the mobility. So our plan here was to fix just L3 to L5 and save at least 1 or 2 levels for the lumbar spine. Because the main level was L4, L5 and there are some subluxation seen at L3, L4. If you need to see on the X-ray.
Yes, sir.
There are some subluxation at L3, L4 facet as well.
L4 your voice is not very clear.
Manoj, can you just your voice is a little unclear.
Oh, sorry. Is it audible, sir, now?
Yeah. A little louder, please.
Yes, sir. So we just went with the fixation from L3 to L5 so that we wanted to save 1 level below, at least at L5 S1. And we had to fix L3, L4 because there was some subluxation at L3, L4. So we had to involve the L3 vertebra as well. And we did anterior column reconstruction at L4, L5. So anyone want to add anything here? Like do anything different apart from this?
Sir, why was the anterior reconstruction needed in this? Only to save a level?
No, because there was subluxation at L3, L4, right?
No, sir. L4, 5 का जो anterior L4, 5 का जो anterior reconstruction किया है.
हाँ, because there was disc injury at L4, L5 as well, no?
अच्छा. Okay.
Take out that disc and then reconstruct it anterior.
Okay, sir. Thank you,
sir.
Sir,
you would like to add anything here, sir?
Manoj.
So I'll do 2 points. I hope Gaurav understood what we are saying in saving levels. The concept in saving levels is to try to not go down to the sacrum because you want to maintain mobility at least one segment. So we don't want to go down to the sacrum. Okay. The second point is, as Manoj said, we did a discectomy at that level. So anyway, in that anterior discectomy done, we would want an anterior construct which will help in fusion more because obviously those facets on that side must have all got spoiled. We all know that the intertransverse fusion doesn't give you great stability except for degenerative cases, not for a traumatic. So I think completely justified in doing a anterior reconstruction. So I think, yeah, I mean,
Sir, any comments
there's
about
a-
the PEEK versus titanium cages in trauma?
I use titanium actually, period, in trauma. Wherever I've never used PEEK actually. If you ask me if there is a reason, I don't think so, because the argument is that if you achieve fusion, whether you achieve it from PEEK or titanium doesn't matter.
Yeah.
For me, I think unlike degenerative, which is a slow progressive condition, trauma is an acute condition. I cannot wait for that fusion segments to completely consolidate. I would rather want something which is stronger in implant quality to hold up to my, anterior reconstruction. So yeah, I mean, titanium for me for all fractures, if I'm doing a reconstruction anterior.
There's a question about this junctional segment, and I just want to come in and clarify that, we make a big deal of junction, and if you're crossing a junction, if you're stopping at a junction, you should cross it. This is completely untrue, and it's just a figment of someone's imagination who said it somewhere. Especially in the lumbar spine, you've got to save as many levels as you can. So just because you've gone to L5, it doesn't mean you have to go to S1. So you can stop 1 disc, 2 discs, 3, as many discs as you can save. Coming to the thoracolumbar junction, what we call the junction is actually not the junction. We say T12 is a junction, right? So if you go from the bottom, if you're stopping at L1, you should go to T12. That's incorrect, because T10, 11, 12 are floating ribs. So there is movement happening at 11, 12 also. So technically, the junction will be T9. Okay. So the concept that if you're coming close to a junction, you should cross it is a completely incorrect concept. The correct concept is you look at the sagittal profile and do not stop at the top of a kyphosis. So if your T12 is going into a kyphosis, you don't stop at T12, you get to T11 or T10. If you're coming from the top and your L1 is going into a lordosis, then you don't stop at L1, you go lower. That is the concept. So don't go by junction and just take that concept out of your head.
Okay. Thank you, sir.
One more question on the chat box. Why there is a connecting rod at L3?
Stability.
To give an added stability, sir, and that's all.
Actually, you could do without this. So the
Yes,
question is relevant and question is sensible. Like if I was the surgeon, I would have probably not put the rod. So
actually, even
sometimes
I
you
don't
feel your
remember,
screw
sir, why.
hold is not good and you put the rod to help the screws, but otherwise there's nothing specific here.
Yes.
All right. Do you want to go to the next case?
Yes, sir. Yeah. So going to the next case, sir, a 50-year-old male presented to us with a history of fall from tree, and he sustained a polytrauma with injury to hip, back, and right leg. He presented with a GCS of 15 and vitals were stable. He has a complete paraplegia below L1 and X-ray. This is the X-ray showing a complete 3-column injury with fracture dislocation at D12 L1 with complete collapse of L1 with retrolisthesis. This is the CT. Can anyone classify the fracture here? What type of AO classification and T-Leak score?
L1C, sir.
So it's a type C AO, right?
Yes, sir.
And neurology is N4.
N4.
Yes. And what is the T-Leak score in this?
T-Leak should be with N4.
Is it complete
M1.
paraplegia?
Yes, sir.
Surgeries?
Complete spinal cord, so should be N4. 4. The score, sir.
Gaurav, he's asking you the score. So you have to add up all those points.
Or it should be around 13. I mean, 8 points for C type of injury. Type C, and N4 is 4.
Yeah, that is AO scoring. This is the T-Leak scoring.
But only T-Leak is 8, sir.
Only T-Leak is 8, yes.
Only T-Leak is 8.
So what would be your plan in this case?
Show the images back,
Yes,
Manoj. Yeah.
Wow.
Go back, Manoj. Go back. Yeah.
What's the one thing in the MRI that you shouldn't be impressed about if you actually look at it? MR. For all of you, MRI dikha na Manoj? If you look at, just look at this one. What's something which you can see in the sagittal which is significant? If you look at the amount of
Cord confusion, you are saying?
Yeah, cord contusion, which is far proximal to the level of the fracture, goes right up at least 3 levels above. Not that it alters your treatment, it's just the, So how many levels above and below?
Most likely 2 level, above 2 level.
How many of you are happy with 2 or would like to go down to 3?
3, sir.
You, just because I said 3, you are saying 3.
2 above and below should suffice.
Is there any downside of going long? Barring the cost of 2 extra screws? Anyone?
So you still have 2 discs intact, no?
Yes, sir. You said
The
to save
entire
levels
column
wherever
is,
possible.
destabilized, and that is why 3 level above and 3 level below is better.
So on one end we said you should save levels, which someone pointed out, and here we are saying go longer.
It is not junctional. It will be in the L2, 3, and L4.
Yeah. So basically, sometime back also we discussed this. This person has a gross neurology, so his paraspinal support system is going to be very, very poor. So you do a short fixation, it's going to give way. His muscles are not going to participate in. So he needs a long fixation no matter what. So here you have to outweigh the saving levels to the stronger fixation. You do a 2+2 in a C-type translational injury, it's going to give way once you put this guy on rehabilitation. If you do a 2+2, you'll have to have a very strong anterior column support, which typically you don't want to do in this, messed up intracanal fracture. Yes, anyone else? Any questions?
So finally, sir, we'll be going for the 2 or 3, or we will be using the sublaminar in this.
So sublaminar is restricted to people who have a poor screw hold, which is osteoporotic older people. This, I believe, is a younger person. Sublaminar is a good idea in the lower thoracic rather than the upper lumbar, because the hold in the lumbar spine of the sublaminar wires doesn't allow derotational potential. Like it doesn't stabilize rotation. Okay, so it's got a poor rotational stability. So in the lumbar spine, if you're ending up in the lumbar spine, that's fine. But, in a case like this, which is I think it's an L1 fracture, right? So you would prefer a sublaminar wire construct if this person was grossly osteoporotic. Otherwise, no sublaminar wires here.
So longer construct as an anterior reconstruction?
I just feel that so I was thinking 3 levels above and below, and 3 levels would include that 5, 4, 3, 2. You should have a 2, 3, and 4 fixed. You'll get a good hold in 2. Obviously, you can't get anything in L1. And anterior, I think, just a graft. The only thing is, it might go into a shortening phase there because there's a lot of loss of bone. I wouldn't probably need an anterior reconstruction, as in cage and all that. I just feel you can dock it and you'll get away with 3. So D10, 11, 12 for me, L2, 3, 4 for me. And like Abhay said, long segment. And you still have 2 good discs. So whoever was asking that question, whether, you still have good 2 discs. So why bother? And they're not too bad either. So.
Right. Manoj, what did you do and can you justify?
Yes, sir. So we went with long segment posterior stabilization, sir, with anti-column reconstruction. Just like sir said, 2 level below, but 3 level above, and we were able to get an index screw at L1, sir, on one side, and then anterior reconstruction using bone graft.
So just one question: if there's a pedicular fracture on a CT, could you still put a screw?
Pedicular fracture at that fracture level?
Yeah.
No, I wouldn't. See, these are already.
How do you decide if you want to put an index screw or not?
Acha, that's what you're
The
asking me.
screw in the
No,
fracture.
I wouldn't. And in this case, so it's irrelevant because you anyway have got good long segment fixations above and below. That one index screw probably is not going to add up to anything much. Not that it's wrong, but I'm saying is that you don't, and I just accept it and don't bother to put it at all. I would rather
The
not
concept of the index screw came to reduce the lever arm on the unstable segment.
Yeah.
So the closer you fix to the unstable segment, the less there's going to be a mobility there. However, you can't be using it indiscriminately. And what Dr. Harshal pointed out is that the screw should have some hold, and the screw only gets a hold in the pedicle. So on one end, you may have a destroyed body, but intact pedicles, you must want to put, put a pedicle screw. But if you have a destroyed pedicle, then you're just wasting time, effort by putting an index screw.
Yeah.
Is that clear to everyone? Any other criticisms on this surgery? I think it's a well done surgery, Manoj.
Should we go ahead with the next case, sir?
Okay.
So this is the last case. So a 40-year-old male comes with a history of fall from height with a polytrauma and GCS of 12. The vitals were stable. Similarly, he had paraplegia. On AP X-ray, we can see that there is no much significant. It doesn't appear to be a significant trauma, but we know that there is something happening at D11, D12. But on seeing the lateral X-ray, so horrifying. So there's a fracture dislocation at D11, D12 with complete transaction of the cord, sir. So can anyone classify the fracture and the T-League score in this case?
I 1 D12 D12C.
Yes.
D12C and N4.
N4.
Okay.
Yeah, Manoj, carry on.
Right, yes.
Yeah.
So what would be a line of treatment in this case, and what other injury would you be interested in looking for in such cases with complete transaction of cord and such a severe displacement?
Organ, soft tissue, organ injuries
Yeah.
more common in this. Such high velocity injuries.
Could there be any vessel injury in this case?
Vascular injury, sir, anterior vessels.
Diaphragm injury can be possible.
So what would be your line of management in this case? What would be your levels of fixation, or how would you go ahead with this? Whether would you do anterior reconstruction, long segment or a short segment fixation? And how would you reduce the fracture in this case?
Yeah, that's the question. Any tips on reducing this fracture or reducing maybe getting an alignment better?
Everyone is quiet. Someone
Dr.
take
Aditya, you want to
tip
come
and
in?
answer.
Dr. Aditya Kashikar, you want to come in?
So basically, in such cases, usually I try to put first screws, and then I put short rod in the proximal segment, short rod in the distal segment, wherever I have put screws. And already patients, I think neurology is 0, if I'm not wrong.
Yeah.
So actually damage has caused at the time of impact only. So reduction is also important. If at all, so I try to, with those short rods proximally and distally, I try to joystick them. If at all I could do that. Okay, there are sometimes, and with such high velocity impact fractures, obviously at the fracture level, the facets are parts, everything is fractured. So I try to joystick them, try to reduce them, and most of the times I have succeeded in those cases.
Abhay sir, any comments?
Sorry, I missed that. My wife.
Yes. So basically, said 2 short rods proximally and distally, and try to have a better lever arm to joystick it better.
Joystick it because already neurology is 0.
Yeah.
So that is how I try to do it in such cases.
Yeah, I think that's a good maneuver. I think my bigger concern is about the great vessels, because sometimes there are injuries to even the intercostals. not just the great vessels, which have got kind of clotted, and you start reducing, and that can get disrupted. So you got to be very worried, and you're overtly worried about a vascular problem, and be slow in your approach. I mean, Dr. Aditya's trick is great, and asides of that, I am shamelessly shortened the column. So I just drill through and make it, instead of leveraging it too much, I try to glide it across as much as I can just by cutting through, because I don't want much action happening in terms of angulation and stretch on the anterior structures, because nothing's going to help here. All you need to get is a biomechanical alignment and then long fixation. So go and cut through the bones as needed and put this in.
You take off the D12 vertebra, sir, here.
Like I would shave off whatever comes in the way of a floppy reduction. It's a floppy reduction because of 3-column injury. So if something's blocking, just like a facet in the cervical spine, you just cut it rather than manipulate it.
Sir, can we have in such a gross displacement of the vertebral bodies, even before operative procedure, some skeletal traction like that we can apply, and then we can check for the pre-operative alignment?
You can, but I think it will be a very cumbersome process, na? Have you done it? What is your experience, Virendra? Because you worked in paraplegia units.
No, sir.
I think it's a cumbersome process to put a traction. You're just like delaying the inevitable.
Yeah. And sir, again, it cannot be actually controlled, because it can cause a kind of a stretch injury to the major vessels, because there's no tether which is holding it together.
You're right. Traction should be contraindicated in a 3-column injury.
Yeah.
Okay. Any other thoughts or questions? Manoj, the exciting question is, what did you do?
What did you do? Oh, wow. Oh, wow.
Is this the same patient?
Yes, sir, same patient.
So I was just, if I might, in this particular one, I would rather expect the moment you kind of put him in place in positioning, you might actually get reduction. Unlike a purged facet of a cervical spine or a bilateral facetal dislocation in a cervical spine, the amount of trauma that's led to this injury, I think, if I'm not wrong, Manoj, the moment you put him prone, most of the reduction must have just happened.
Yes, sir. Exactly, sir. It was a fresh injury, sir. As soon as we turned him, we had a very good alignment.
And that's why you got such wonderful post-op reconstruction, because it was so supple. I think it will be like two ends of the body hanging on a spinal cord, that it's almost like that, so this must have got reduced easier. Unlike cervical, I mean, cervical facetal subluxations and dislocation are ruthless. Ruthless means you try your best with every mechanism, and you still have to sometimes go anterior, posterior, and anterior to get things sorted. This one, I think, would have just fallen in place. I mean, that was just my thought.
Sir, in such cases with complete transaction, if there is some translation even after all the attempts, so would you accept it, sir?
Yeah, just accept it. Just accept it. Yeah, sure. Just accept it. I don't think you should shy from the fact that, you will look at it radiologically suboptimal, but that's not your concern at all. I think your concern is to just get him out. In such scenarios, if you've got good fusion happening anteriorly, that small step for translation just doesn't reflect. So I think do what's the best. And I think it looks wonderfully well. And that's why I said probably it reduced easily, because very difficult to get such nice alignment.
Sir, what if there is any neurology is there with this dislocation? We have to fix in situ, or we have to reduce it and then fix?
So in a transaction of a cord, what is your ultimate aim? To get him out of... You're not talking about this case?
No, not this case. I have seen one case with like dislocation like this only, with some neurology is there.
Neurology intact?
Yeah, some neurology.
Basically, if neurology is partly preserved, the onus on your surgery becomes much bigger, because you're very likely to damage the neurology than help the neurology. In a massively dislocated spine where the cord is still functioning. So normally we like to do intraoperative neuromonitoring even before positioning. Like for positioning also we do neuromonitoring. We do a wide posterior decompression before we try to attempt reduction, and we do everything under neuromonitoring, and it's a high risk procedure. Is that okay?
I have seen, sir, one case like this only. Neuromonitoring was not done, but the consultant have fixed in situ like this with dislocation only. 5/16.
That's a suboptimal surgery. I guess he did it because there was no neuromonitoring, but in the end, that's a suboptimal surgery because if you not not realign the biomechanical axis of the spine, your chances of implant failure are much higher.
Was his neuro still preserved post-op? Whatever was left?
No, yes, sir. It was preserved.
Preserved. Okay. Not Manoj, not to you. Not
this case, sir. No.
Yeah. Okay.
But your point is taken. If you have no neuromonitoring, I guess you want to minimize your, your manipulations.
Sir,
right.
Yes. Sir, last question. Just for discussion's sake, because as earlier also someone pointed out, how do we prognosticate or how do we counsel such patients? So during pre-op counseling, do we take separate written negative consent on paper, and do we take patients and relatives' signature on paper along with may or may not be with video consent? What is your take? Question is for Nini sir and Raghu sir both.
For a patient who's complete neurology, like zero power,
or maybe incomplete neurology. Both.
Because incomplete neurology remains the same problem as a TB spine or a tumor or any surgery we do where there's a potential for neurological deficit. I think the ones that are complete neurology, if you're asking, are you worried that after surgery they'll come and say that why didn't he recover? I don't think we are. I've almost never worried about that because the evidence is heavily stacked in our favor. So even if they went to court, the net percentage of a dense paraplegic to recover. Anyone with a dense paraplegia or quadriplegia who's presented in the casualty for any etiology, the chance of recovery are under 2%. That's the worldwide statistic. So if he takes you to court, also he's not winning it because the literature is heavily stacked in our favor. So I would not much worry. What I definitely do is give a very massive negative counseling to the patient's relatives because they invariably after a week say abhi chalega kabhi. But I give a very positive counseling to the patient because we need him and his entire resource bank to be proactive during the rehabilitation. So we look for every small thing and try to make him even sometimes do cheat movements and tell him look you're recovering. But all the relatives and the next of kin are aware that this is all sham recovery. Raghu?
Yeah, completely agree. I think, you can do your best with medico-legal consent, Aditya. But for every word you put in, there is another loophole somebody else can open out. Right? There is no endpoint. I know of people who have 6.5 pages consent in 3 languages. But if he has to, he could just stand and say, "I never understood what you said. It was the language of my understanding." What do you write normally? You write it as my language of your understanding. He said that it's a language I understood, but I never understood what you said. So there are enough medical legal loopholes. I think one part of it is the empathy part, which Abhay said, be aggressive with the relatives, but empathize with the patient and have enough and more medical legal requirements in place. I know video consent is being really, it's on the upscale in most places. I haven't done it myself, actually. I have to say that I haven't done it too many, except a few cases where I was finding a little difficult to handle the relatives, but I don't use it. But it could be the future where everything has to be put on video consent. Yeah.
Okay.
Sir, one more point. Basically, just want an opinion. A cord level contusion, is this a sign of or is it a risk factor for a post-operative neurodeterioration?
Not necessarily. Sorry.
No. The question is a radiological cord contusion.
Radiological cord contusion when you operate and early operation, because the edema and inflammation can actually worsen over a period of time. So, do you counsel them for a post-operative neurodeterioration?
Well, I don't think literature supports that. Literature doesn't support a cord edema in an early setting to be a negative risk factor for neurological deterioration.
Okay.
But I think the message we all want to give everyone here is that if it's a partial injury, you have to be very, very careful during your surgery because the worst thing you can do is make it a complete injury.
Yeah.
And this stands even for someone with a useless power pre-op. Power that's really not worth it, but they know that they're moving. Post-op, they don't move and they just, they think they were walkers before and they were not. And this is especially true for bladder. because they feel that they're passing, but it's a urinary overflow, and then they stop passing. So all that not consent, but they have to be counseled well regarding catheter and regarding the inability to walk, and you have to make provisions for good rehabilitation. Right. Any other questions?
Sir, if there is
Yeah.
if there is a cord contusion with intact dura, then it's good to do the dura decompression.
So durotomy was in fashion in the past. Now it's almost given up. Yeah. But with Raghu's paper, I don't know if we should now restart doing durotomy and open up the roots. But they still sometimes do it in long-standing, untreated, old heel fractures with an internal gibbus, where the dura could be scarred and dura could be the teether. And you can do a durotomy, keeping the arachnoid intact to release to let it herniate out. But I've been in an era when it was done, but at least I've not seen any results. So personally, I'd never do it now. There's no one else I know who does it. I don't think anyone in the faculty also does it.
No, not at all.
No, thank you.
Dr. Gaurav, you had a question?
3 runs in 5 balls.
So guidelines of fixing or the number of screws or in a combination of fractures. I mean, if L1 and L3 is involved or D12 and L2 is involved. So how do we go about fixing them? Isolated short segment for each of them.
How will you do isolated short segment if you have a L1 and L3? Anyway, you're going to encompass the entire thing, correct? You've got just an L2 in
not so close.
Yeah,
not so close, sir. Suppose the patient has a burst fracture of D8 and L3.
Yeah.
What do we do in these cases?
No. So I think my approach in these cases will be you individually treat each fracture the way it needs to be treated.
Okay. Yes, sir.
But at the end of the day, if you realize that your D11 fracture needs a long segment fixation, which might need to go right up to L2 or L3, or say L2,
yes,
and your next fracture is L3, but the L3 can get away with short segment fixation, then you just extend it from whatever D7 to L4. You understand what I'm saying? So just because you have contiguous fractures which are at a gap of 2 or 3 levels in between them, you treat an individual fracture the way it is. If cumulatively ends up fixing the whole segment, fair enough, you do it. If you don't need it. So I don't think, basically you treat each fracture by its own face value. Don't try to combine both.
Okay, sir. Thank you, sir.
Sir, in case of paraplegic patient, I have seen some patient with bed sore, not healing bed sore, with proper rehabilitation. Even after rehabilitation, it is not healing. So what is the reason, sir?
So I think the last answer is that you are not properly rehabilitating. Because if Michael Schumacher, as we know, had no bed sores at the end of the day, with that kind of injury he had, probably he had the best of care, correct? So I think the fact that he's developed a bed sore, our care isn't good enough. Whether the care is because of your urinary catheter not changed often, or you are not changing positions often, you might find fault with the whole thing, whatever the reason, but the care isn't good enough. I think that's just about it. There is no other justification.
I think it's a very big topic in itself about the paraplegics and that care, how to take care of the paraplegics in every aspect. Let it be bed sore, let it be respiratory infections, let it be boil and bladder involvement. I think one must be aware of those things when they're managing trauma and paraplegics.
Sir, if you have any video regarding this, then kindly share it.
Definitely, we'll try to share some papers.
Of rehabilitation, you're saying?
Papers, yeah, rehabilitation.
Okay, yeah.
Should we cover any questions? Yeah, Harshad, please.
Yeah, please, sir, carry on. Sir.
What about implant removal in traumatic situations, sir, after 2 years? Short segment, especially when we think it is good enough that it can be removed, especially youngsters, active individual.
So actually in my career till now, I've done it only once. And interestingly, this guy was, I had done a minimally invasive fixations for L2 fracture, if I'm not wrong. And he was this go fast, traveling right around the country in different formats of modalities of travel. He fell off the Indigo slide, the Indigo, what we call this. You get out of the plane and you have this a small sliding thing that you walk. He slipped off, fell, and actually broke the implant. Now I knew if you had time to wait, it would have probably not caused a problem. But he was persistent on getting it out. So as persistent he was to put it minimally invasive, he was persistent to get it out. So I took it out. Barring that, I can't remember any that I have removed. No, I can't actually, no. See, because in the thoracolumbar fractures, see, if you have to remove it, it's going through the same thing. I mean, for the patient, it is the same, isn't it? He has got to get into the hospital. You have to go under GA. Most times when you tell them all that, they kind of say, okay, it's not required, then let's not do it. But in him, I remember because he broke the implant. So not often that we do implant. I don't know. I mean, what about others? I wouldn't know, but I haven't done.
Yes, same here. So not removed as such, but yeah.
Yeah.
I think it has to be planned earlier. If you want to remove it, you have to protect the facet before putting the screw.
Yeah.
I mean, it has to be really planned too early. Yeah, any other questions? Or let's conclude.
Right. I think we can conclude. It's gone on long. I think it was a very good session on a very common topic, and we covered, I think, most bases. What we haven't covered is, of course, cervical, because it's not a part of this, but even osteoporotic trauma comes as a completely different pathology, and we will touch upon it in the future. If you have any other questions that have been left unanswered, we are available round the clock on our WhatsApp chat. But don't leave anything unanswered in this entire fellowship program. And thank you, everyone. Thank you all the participants for taking out time, and Raghu for that fantastic talk.
Thank you, everybody. Thank you.
Thank you, sir.
Our next session will be announced in a couple of days.
Yes, sir. It will be next week, adult deformity. I think Dr. Nini was going to talk about adult deformity.
Okay.
Yeah.
So next Thursday or Friday, we'll just announce that in a day. All right.
Yes, sir. Yes, sir. But the final date will be announced shortly. But I think it will be adult deformity most probably. I'll anyways update in the group.
Perfect. All right.
Wonderful. Thank you. Thank you, everybody.
Thank you,
sir. Thank you, Raghu, sir. Thank you, everyone.
Thank you, sir.
Thank you, sir.